Good evening. I think you are tired because it was a long one. So last but not least, I must say, really, somatostatin analogues. You heard this morning that somatostatin is our friend. It's the friend of the patients and the friend of the doctors. Why? Because it's, as Eugene Waltring said, the universal brake. It inhibits many digestive functions, many hormone releases through specific receptors. And as you can see, natural somatostatin is a 14 amino acid peptide which binds to 5 subtypes of receptors. What is more interesting is that octreotide and lanreotide are shorter peptides, 8 amino acids, which have good affinity, comparable affinity with SST2 receptor. And the point is, as you heard from previous speakers, that this explains the binding of these analogues to the receptor, the effect of the peptide as for the treatment as well as for imaging. As you can see, this is not the octreotide and lanreotide have a much lesser affinity than the natural peptide for other receptors, which fortunately do not seem too much involved. But this is not for sure, and Carcinoid that you heard about also has indeed affinity with a greater number of somatostatin receptors than octreotide and lanreotide. The biological effects of these receptors are really very interesting in many aspects. Somatostatin inhibits the release of many hormones, growth hormone, gastrin, insulin, glucagon, most of which are involved in tumor growth. Moreover, somatostatin has direct effect on cell proliferation. It induces cell cycle arrest and it induces programmed cell death. So there are many good theoretical reasons for use of these drugs as inhibiting tumor growth. So, in summary, inhibition of hormone release with topic effect, inhibition of many growth factors, of growth of vessels, of modulation of immune response, and direct effect of tumor cells. So as you can see, many reasons for the use of this kind of drugs. When we use somatostatin analogues in our patients, we have 2 main therapeutic objectives. The first one is to reduce, to control symptoms linked to hormone hypersecretion. I must say that this is the only indication that is currently approved in Western countries. And as I just shown, the second goal, which is not officially approved because it lacks real and definitive evidence, is to inhibit tumor growth. So you can see that, like interferon finally, somatostatin analogues might be used as well as for symptom control and as some kind of cytotoxic treatment of biotherapy. We started in the 80s with daily multiple subcutaneous injection with the first analog available, which was octreotide. And as you can see on the summary of these old studies performed at that time in a rather limited number of patients, using 3 times daily injection of 100-150 micrograms each in a median, we got quite a satisfactory control of the major symptoms of the carcinoid syndrome, which are, as you heard a lot of times, flushing and diarrhea. And on the whole, we got an efficacy of these symptoms from 50 to 90% of the cases, and in a significant minority of the patients, we got a total disappearance of these symptoms. Very interestingly, this was paralleled by an effect on the urinary excretion of the hormonal marker, which is 5-hydroxyindole acetic acid, 5-HAA, which in quite half of the patients decreased by at least 50%. Then came a second analog, 10 years later, roughly, and only in Europe at that time, which is lanreotide. And lanreotide was from the beginning developed as a slow-release compound, which was avoiding multiple daily injection. At that time was only available a 30 milligram formulation, which still is available today, allowing one injection every 2 weeks. That was a significant improvement in patients' comfort, of course, and we showed in 1996 that slow-release lanreotide significantly improved flushing and diarrhea during a 6-month treatment in those patients who got carcinoid tumors. Once again, symptoms disappeared in 40% of the patients. We then went into a comparison of both compounds. Well, I would say not that a fair comparison, because we were comparing what was available at that time, a 3 daily injection of octreotide and 1 injection every 2 weeks of lanreotide. The order was randomized, half of the patients starting with octreotide and the others with lanreotide. What we showed and what we aimed to show was to determine was the preference of the patients. We just asked as a major criterion, what do you prefer? The first objective was not, do you have less diarrhea or less flushing? What do you prefer? And the patients, at least the majority of them, 68% of them, said, we prefer lanreotide. And why did they prefer octreotide? For the major reason of the convenience and more or less related an improvement in quality of life. But as you can see, it was not because the efficacy of both drugs was different. It was the same. Indeed, half of the patients found that octreotide or lanreotide was more efficient than the other, and there was as well no difference in the side effects. So the advantage of this formulation was clearly the lesser necessity of injections. We, of course, had secondary criteria and showed that both compounds were equally efficient in decreasing flushing, bowel movements, or 5-HAA in the urine. Then came the time of the very long-acting analogues, and this was the year 2000, and the first one to be available was octreotide, LAR, and this is the famous study showing the efficacy of long-acting octreotide in patients previously treated with short-acting subcutaneous octreotide. And as you can see, those patients, nearly 80 patients, were divided in 4 groups. Some of them continued with the subcutaneous octreotide, and the others received either 10, 20, or 30 milligrams every 28 days during 20 weeks. And what happened is that those 4 possibilities, so subcutaneous continuation or long-acting drug, and there was not, as you can see, a clear dose relationship because the efficacy of the drug was more or less the same, whatever the dosage, with, however, a trend of a better efficacy of 30 milligrams. Was that, as you can see, this is representing the number of flushing episodes per day. This is the baseline, then this is the discontinuation of the treatment, so there was an increase to a mean of 4 flushing episodes per day. And when starting the long-acting treatment or continuing the subcutaneous form, there was a strong decrease to less than 1 episode per day. So this was the demonstration that long-acting octreotide was very efficient on flushing and also on diarrhea, as you can see, a little bit less than on flushing, but you can see that patients come back to their 2 to 3 bowel movements per day. During this long-acting use, patients were allowed, if necessary, if symptoms made it necessary, to use rescue injection with octreotide. As you can see, whatever the dose of long-acting, around 1/3 of the patient made daily shots when flushing and or diarrhea were not totally controlled with long-acting. What should be done when this kind of treatment fails or when there is an escape? It depends on the symptom, and I would insist upon the fact that diarrhea is not only a symptom of the carcinoid disease. Patients who have got, for instance, a bowel resection, and of course this is frequent when you have been operated on for your carcinoid tumor, may have a bile salt-induced diarrhea or a bacterial overgrowth. And this has to be treated by specific drugs and not necessarily by octreotide or lanreotide. Pancreatic insufficiency may also be responsible for diarrhea and necessitate a specific treatment with pancreatic enzymes. And this finally and paradoxically could also be a side effect of somatostatin analogues. As I mentioned, a rescue injection increased octreotide dosage up to the highest, 30 milligrams, and then decrease the intervals between the injections if necessary. And we should not forget that the best symptomatic treatment is also anti-tumoral treatment and reassess the possibility of surgery, of chemoembolization, chemotherapy, interferon. And I didn't mention it here, but what we found is that in some cases, patients who become resistant to one analog might, in some cases, benefit from the other. So escape to octreotide might be treated by lanreotide and conversely. The last born in Europe, and I'm happy to hear and to know that it's now available at least in another indication, which is acromegaly, in the States and in Canada, is lanreotide. Lanreotide or somatulin is a new formulation of the lanreotide I mentioned earlier, which was the 30 milligram. Now we are dealing with an autogel. The first one was not an autogel, which is 60, 90, or 120 milligrams. It's used in very convenient pre-filled syringes, and the mode of injection is subcutaneous. It's not intramuscular as for octreotide. And as you can see, the volume to be injected is rather small, 0.2, 0.3, or 0.4 according to the dosage milliliter, which more or less makes it look like an insulin injection, although the needle, I must admit, is a little bit bigger. I conducted a study some years ago, which was the first one to be made in patients with carcinoid syndrome once again. And we had very strict criteria, at least 3 stools per day and at least 1 moderate severe flushing episode per day. There was a washout period to allow clinical symptoms to reappear, patients in good general condition and who signed consent. And we compared the symptoms to what they were at baseline as far as number of stool episodes and flushing episodes were concerned. And the patient chose one target symptom. He said, diarrhea or flushing is the symptom that bothers me the most. And this was called the target symptom. And we defined a responder very strictly by at least 50% decrease in the target symptom. So a small majority of the patients chose diarrhea as the target symptom. They had 5 plus minus 2 bowel movements per day, which is a lot, and flushing 4.6 episodes, which is also a lot. What happened when we treated these patients was that we observed a very significant decrease in flushing and diarrhea. Much more, I must admit, in flushing, left part, than in diarrhea, right part of the slide. only 23% of the patients had a significant decrease of bowel movements. The explanation of this is hard to precise because this was not really confirmed later on by the clinical experience. If I come to the responders as I defined, so 50% decrease in the target symptoms, 38% of the patients were responders on the target symptoms, and once again there was a significant difference between the proportion of those who responded to flushing than to diarrhea. And 5-HAA levels decreased by 24% in mean in these patients, as chromogranin A decreased by 38%. Let's come now much more quickly, because there are less data, to the other functioning tumors. There are two, in Europe at least, for which somatostatin analogues do have an indication, vipoma and glucagonoma. You heard this morning about these patients with huge amounts of stools, up to 10 liters per day, so it's life-threatening, obviously. It decreases serum potassium and it may kill the patient from heart complication. In this situation, obviously, octreotide and lanreotide have totally changed the prognosis by controlling the diarrhea and at least allowing the patients to go to anti-tumor treatment, surgery or embolization or whatever, or chemotherapy. And in glucagonoma patient, diabetes and those very impressive skin lesions, which are called necrolytic migratory erythema, diarrhea and weight loss are very well controlled by somatostatin analogues. In gastrinoma, in Zollinger-Ellison syndrome, it's possible to control gastrin and acid with somatostatin analogues. However, in this respect, these drugs are much less potent than PPIs, than proton pump inhibitors. So they are not widely used for this reason. And in insulinoma, I think you should know that we are very careful because results are unpredictable. The somatostatin analogues might as well improve or worsen hypoglycemic symptoms. And so they should be used very carefully among other drugs and under hospital control because it could worsen the situation. And then, very importantly, because even if it is not approved, it turns to be one of the major indications in many countries, the effect on the tumor, not on the symptoms, but on the tumor. We have few studies, but what I could summarize is that when you gather those studies, either with octreotide or with lanreotide, you get, once again, those important stabilizations in nearly half of the patients. But, as finally with all, and Kjell very elegantly mentioned it in the previous talk, as all with these new therapies, these biotherapy, these NIBs and MABs, you don't see a lot of objective responses. And I think that here, we should be very careful and very hopeful in this 40 to 50% of stabilization. Of course, stabilization means that you have carefully documented tumor progression before initiating treatment. So you stabilize half of the patient with octreotide or lanreotide. I will go through this one because it's always the same. What about the side effects? I think here you get a clear interest and advantage of somatostatin analogues. In my opinion, somatostatin analogues are probably, from all the drugs that were mentioned today, the best tolerated. It can be responsible for a little pain at the injection site, nausea, abdominal cramps possible. Diarrhea and steatorrhea may occur and be treated with pancreatic enzymes. Diabetes or hyperglycemia may happen. You saw figures of around 10%. In my experience, it's rather rare and rarely necessitating treatment. And finally, one frequent side effect because remember that it's a brake. Somatostatin is a brake. It inhibits the gallbladder motility. For this reason, gallstones may form in the gallbladder. Very fortunately, even if this is rather frequent, these gallstones are very rarely symptomatic, and few patients necessitate some cholecystectomy or extraction of stones in the main bile duct. So, really, I think we can say that side effects of somatostatin analogues rarely lead to treatment discontinuation. So in conclusion, I think that the studies I showed have proven that somatostatin analogues are really a major therapeutic advance for symptomatic treatment of carcinoid tumors mainly, but also lipomas and glucagonomas. And that those drugs, those compounds, take a more and more prominent place in anti-tumor treatment. And you will read on websites and papers in the medical literature expert consensus recommending to give somatostatin analogues as first-line treatment, I mean for tumor control, in those patients with well-differentiated and not too rapidly progressive tumors. I share to some extent those recommendations, and I wrote them in part. However, we should not forget that we have no current marketing authorization, and that the first randomized study, in this case is with lanreotide, comparing the effect on tumor growth of lanreotide as compared with placebo, is just ongoing, so we are waiting. Thank you very much for your attention, and thank you, Maureen.
Thank you very much for a wonderful talk. I was asked by Maureen Coleman to remind you that despite the amazingly late hour, that all the concurrent sessions are actually happening and all the speakers are in the respective rooms waiting for people to show up, namely MEN1, multiple endocrine neoplasia, in Winford Room West, the nuclear medicine session in Winford Room East, and a concurrent session for physicians in the York Room, and that transportation to dinner for those people who have signed up or are signing up will still proceed as scheduled at 7 o'clock.